Our next plenary session is on Beyond Fibrosis, Disrupted Alveolar Regeneration in Idiopathic Pulmonary Fibrosis. I am delighted to invite our chairpersons, Dr. Praveen Weeratunga, Honorary Joint Secretary, Ceylon College of Physicians, and Dr. Amitha Fernando. May I now invite our chairpersons to introduce the speaker. Over to you, sir.
Good morning, ladies and gentlemen. It is my absolute pleasure to introduce Professor Ling Pei Ho, who is a Professor of Respiratory Immunology at the Weeratunga Institute of Molecular Medicine, University of Oxford, and a consultant respiratory physician at Oxford University Hospitals. Professor Ho's research focuses on immune mechanisms of underlying lung fibrosis, specifically idiopathic pulmonary fibrosis and fibrotic pulmonary sarcoidosis, using advanced techniques such as spatial transcriptomics, imaging mass cytometry, and tissue-specific immune mapping. She has led pioneering efforts in the care of sarcoidosis, establishing one of the UK's largest specialist centres and contributing to the development of national standards for its management. Her team's mission is to improve the treatment of lung fibrosis through a deeper understanding of disease mechanisms, ultimately guiding the development of more effective therapies and better designed clinical trials. She will talk today on Beyond Fibrosis, Disrupted Alveolar Regeneration in Idiopathic Pulmonary Fibrosis. Over to you, Professor Ho.
Thank you very much. Let's just make sure that I've got my pointer up, and then I'll go. There you go. So it's an absolute pleasure and honor for me to be here in Sri Lanka at the Ceylon College of Physicians. Thank you very much to Professor Katulanda and the organizers for this very kind invitation. Before I begin, let me say a word about what we do. Dr. Weeratunga has already introduced some of the things that we do in Oxford. I am a clinician scientist, and I run a research program on immune mechanisms of lung fibrosis. This is the John Radcliffe Hospital, part of the Oxford University NHS hospitals. And I know some of you would have spent some time, 1 or 2 years here as part of your working life. And within this hospital, I work with the Oxford Interstitial Lung Disease, ILD service, and look after patients with sarcoidosis primarily, and also with idiopathic pulmonary fibrosis. Now this hospital here is linked physically by a link corridor to the Weeratunga Institute of Molecular Medicine, which is where we conduct our research. And the mission of the MRC Translational Immune Discovery Unit here in the Weeratunga Institute of Molecular Medicine is to pioneer studies in human immunity and uncover the molecular pathways that drive immune-mediated diseases. And we want to try and innovate some of our discoveries to create new medicines. And this brings us really to what's present for the challenges of the physicians of today, and it links it to the future, which is what science could provide in the coming years. So this leads me really to the next slide. Let's see. Which really talks about the theme of this year's Congress, Physicians for the Future, which is really very timely, as so much is now happening, which you're all aware of, which will change, and is changing how we manage our disease today. Changes and new findings in how we predict prognosis of patients, how we tailor our patients with the right biomarkers to the right treatment, and how new tools are coming to fore, which will help us identify novel medicines and therapeutic targets. And on top of all this, AI will help us hopefully speed up all this effort. And in this talk, I will talk about idiopathic pulmonary fibrosis, IPF, and I hope to give something to today's physicians, including myself, on the up-to-date diagnosis and management of IPF. And then for the future, perhaps a glimpse into what we are doing and how science and our research could be changing our understanding of this disease and how it might lead to new drugs in this disease. So we'll be starting off with today and the present. So there are many interstitial lung disease, more than 200, and IPF is really only one of these many ILD diseases. ILDs are diseases that affect the interstitium, the supporting stroma around the airspace and the airways. IPF is really the only ILD that is that fibrosis in all patients. So as you can see here, for example, sarcoidosis, only about 10% will lead on to fibrosis. But in IPF, a disease of the airspace rather than the airways, all of the patients will have fibrosis and will progress. In the US and the UK, IPF, sarcoidosis, connective tissue interstitial lung disease, and hypersensitivity pneumonitis make up 60% of the cases of ILD that we see. IPF is important not only because it's a relatively common ILD for the UK and US. There's very little known about the population-based prevalence in Sri Lanka, but talking to some of you over the last few days, I know this is not an insignificant problem. But IPF is also important because it's a devastating fibrotic lung disease. 50% of patients will die within 5 years of the diagnosis of IPF. It is unlike other fibrotic diseases like fibrotic sarcoidosis or antisynthetase syndrome because it only affects the lungs. And everybody will progress. And the accumulation of scarred lungs over the years will inevitably result in respiratory failure and death. The diagnosis of IPF itself is actually quite important. Arguably, the inability to call out this condition, idiopathic pulmonary fibrosis, from that of fibrotic hypersensitivity pneumonitis, fibrotic sarcoidosis, rheumatoid arthritis lungs, and connective tissue ILD, has clouded the management and drug development over the years. So the ability for us to say this is IPF does matter. So let me put into context how the diagnosis and management of IPF have evolved over the years. Now, some of you remember this description of a fulminating type of inflammatory lung disease called the Harmon-Ridge syndrome. And it was actually the first time back in 1944 when IPF was first mentioned. Of course, we didn't call it IPF then. And then many of you will know in your medical school years, perhaps being taught cryptogenic fibrosing alveolitis, where the patients will have rubbery, fine crepitations at the bases and finger clubbing. But it's really in the 1970s when Liebov, the father of lung pathology, an Austrian American, who began to classify these interstitial lung disease into different categories histopathologically. He looked at the lung sections and realized not all ILD, and in fact not all CFA or cryptogenic fibrosing alveolitis are the same entities. In the early 1980s, high-resolution CT scan began to be used, and it revolutionized how we looked at interstitial lung disease and IPF in particular. And that led to the first ATS-ERS statement in 2002, which specifies the importance of clinical, radiological, and pathological diagnosis of IPF. And rather quickly, well, perhaps not so quickly, but it led to a huge number of clinical trials, which first randomized clinical trial in 2011 showing benefit for pirfenidone, which is one of the two drugs that we now have licensed for IPF. And then a refinement of the ERS ATS guideline, which specifies the importance of multidisciplinary team guided diagnosis of IPF. And then quite quickly to the introduction of nintedanib and then for IPF in 2014, and then for progressive lung fibrosis in 2019. And a few months ago, nerandomilast, a phosphodiesterase inhibitor, met the endpoint for IPF, giving us our third drug for IPF. So, so this is a golden time in a way for idiopathic pulmonary fibrosis in terms of drug discovery, but it has taken a long time and more patients that we want to know. More than 10,000 patients have been involved in these clinical trials. But quite a few of this progress, as mentioned, has been due to the ability for us to call this IPF rather than ILD. So what makes an ILD and IPF, idiopathic pulmonary fibrosis, and why is it important? So the most important feature in IPF is the presence of UIP, or usual interstitial pneumonia pattern on the CT scan. And this usually requires a high-resolution CT scan, but not always for this diagnosis. And the recent guideline has divided this into definite UIP or UIP, probable UIP, or indeterminate. And we should be able to, with radiologists, call the difference between these three entities on CT scans. Almost always these days, the histopathological pattern is not really required, and most of the time, diagnosis can be made on the HRCT alone. But the reason why it's important to call it IPF or non-IPF is that if you are given the diagnosis of IPF, then your prognosis is really poor. But if you are given the diagnosis of not IPF, then some will actually have very good prognosis. So patients with fibrotic sarcoidosis, hypersensitivity pneumonitis, RBILD, which is due to smoking, have an excellent prognosis. The other important thing is that patients with IPF, for patients with IPF, steroids and immunosuppressants are not helpful and can actually be harmful, whereas steroids can be curative in some patients without ILD patients without, which is not IPF. So it's relatively important to make that diagnosis. And what is UIP, or usual interstitial pneumonia CT pattern? So this is a very characteristic pattern, so much so that pulmonologists in ILD can actually do this almost without radiologists. So this is a pattern characterized by presence of reticulation and architectural distortion, traction bronchiectasis, as you can see here, where the airways are pulled apart by the fibrosis. But critically, in the peripheral distribution, subpleural usually, and with a predilection for the basal areas. It has to lack ground glass changes, unless the ground glass is found within the areas of traction bronchiectasis. So those patterns are relatively clear and well-defined and makes out this UIP CT pattern. And what about UIP histological pattern or histology pattern? Again, this is relatively straightforward now in these days. And this is characterized by the presence of fibroblastic foci, almost pathognomically. And these are young fibroblasts palisading against each other, almost always along the type 2 or alveolar epithelium. And the other patterns are the disruption of normal architecture of the lungs interspaced with actual normal lung structure. So one of the hallmark of UIP histological fibrosis pattern is the presence of spatial and temporal heterogeneity in the lung features. But UIP diagnosis doesn't quite make the diagnosis, the clinical diagnosis, because UIP CT pattern can also be seen in patients with fibrotic hypersensitivity pneumonitis and fibrotic sarcoidosis, albeit relatively rarely. And we can also see UIP CT pattern in patients with rheumatoid arthritis, ILD. So obviously, as physicians, we'll look at other parts of the patient, and the supporting diagnostic features is usually the fact that they are, it's only the lungs that are involved in these patients. And almost all patients are men, and almost all of them will be greater than 65 years of age. So this is our diagnostic pathway in the UK, and I appreciate in here talking with the local physicians, we will have to adopt this in a certain way, but I know that the various assemblies are pushing towards a kind of a more common pathway of diagnosis. So patients are suspected with IPF will almost always have a high-resolution CT scan. But as I said, you don't really absolutely need this. And so I don't want to discourage people from thinking that you can make that diagnosis with a CT, a non-high resolution CT scan. And from this high-resolution CT scan, we'll make a diagnosis of UIP or probable UIP based on the CT pattern, or indeterminate, and then through a multidisciplinary meeting with usually the radiologists, pulmonologists with ILD interest, and sometimes the pathologists, we make a decision as to whether we need to go into any further investigation or whether we can call this IPF. And almost certainly these days, with a typical CT pattern, these more invasive features are unnecessary. So once you've made the diagnosis, the management is actually quite prescribed. Bearing in mind the disease will always progress in 100% of the cases, except where drugs, antifibrotics are used, then we look at the stage that the patient is at. When the patient is at a relatively early stage with a relatively good lung function, then we start all patients with antifibrotics, or we put them into new clinical trials. There's emphasis on patient education, smoking cessation, and treatment of comorbidities, in particular pulmonary hypertension, acid reflux, and the cardiac diseases. As the disease progresses, oxygen assessment and pulmonary rehabilitation becomes more important, and end-of-life preferences in palliative care and sometimes lung transplantation is prescribed. Just a note in the last slide from the clinical side on this thing called AE-IPF or acute exacerbation of IPF. I circle back to the first slide that I showed on the milestone where Hammond-Ridge syndrome was mentioned. And in fact, that was the first recognition of an acute deterioration of a pattern of acute deterioration of IPF. And this is some of the most feared episodes in a patient and clinician's life looking after IPF patients, where the acute deterioration robs the patients of their lung function, and there's 80% mortality within 3 months of AE-IPF. So this is an important step and an important episode in a patient's life, and it's almost always triggered by infection. When you do have AE-IPF, then the treatment is usually aggressive treatment of infection, and only in this case in IPF, steroids and in addition to the antibiotics. But quite often, really, that it's too late when we get to this point, and the emphasis really is on prevention. So nipping infection in patients with IPF as soon as possible to prevent this massive inflammatory response and accelerated fibrosis. So for today's physician, the message is getting the diagnosis right, I think, is important. Multidisciplinary teams is key to this, this diagnosis. Radiologists and clinicians as a minimum for this team. Antifibrotics that we have now slow down the progression but do not reverse the disease. And 40% of patients that we start antifibrotics on eventually stop due to side effects. So there's still quite a lot of work to be done from our points as clinician scientists to try and understand what this disease is about. Management of comorbidities is important, and timely consideration for palliative care, unlike other ILDs like fibrotic sarcoidosis or HP, IPF is quite often a disease at the end of a patient's life. And steroids are not useful for IPF except for where there is AE-IPF. So let's move on to the second part of the talk, which is what lies beneath these clinical features that I've talked about, and something for the future of physicians. So currently the favored concept of disease mechanism in IPF posits that recurrent subclinical epithelial injury in the alveolar epithelium superimposed on the accelerated aging of this epithelial lining leads to the abnormal repair that results in deposition of scar tissues, this fibroblastic fossa that I showed you before, and destruction of the architecture of the lung. Now, what I would like to do is to propose that a different or an additional element to this concept, that fibrosis is, or IPF is not just from the scarring from the laydown of collagen, but the remodeling of interstitium due to the abnormal alveolar regeneration. So we take this to the, from the disease, which is simply of dysfunctional epithelium as an initiator of disease, to a point where the interaction between alveolar regeneration, which is abnormal, with the immune cells perhaps, cause a situation where the disease or the fibrosis is perpetuated, as in the case in IPF. And the reason we say this is because we know that simply lay down collagen is not the whole story in IPF. So let's take a look at this histology of IPF lungs here. This is our normal lungs, air space with large amount of air and alveoli, as you know, that's lined with unicellular alveolar epithelium, providing a fantastic environment designed to for optimal gas exchange. And this is what happens in IPF. The interstitium here has been filled with collagen, but not only of collagen. If you look and any of you really can see that this is a lung that's full with inflammatory cells. Here, for example, in the alveolar space, but also in the interstitium. And if we look a little bit more closer, we can see that the alveolar epithelium is abnormal and regenerating abnormally. And for decades, pathologists have told us that these alveolar epithelium no longer produce type 1 alveolar epithelium, but type 2 alveolar epithelium in a process called type 2 alveolar metaplasia. And not only that, it is clear to many pathologists that this abnormal alveolar regeneration results in bronchiolization of the alveolar lining. So instead of the type 1 and type 2 alveolar epithelium that you and I know from our medical student years, it's now lined with bronchus type epithelium that line the bronchus. Good for conducting air, but not good for exchanging of gases. So what we are saying is that the abnormal alveolar regeneration, possibly with interaction with immune cells, it's not just an initiator of disease, but a perpetuator of fibrosis. So remember that fibrosis is actually a normal phenomena. If you hurt yourself, you will scar, and that's part of healing. But in IPF, this is part of the perpetuation or chronicity of fibrosis makes that disease. And the destruction of fibrosis because of the inability, we think, of the alveolar epithelium to regenerate causes these honeycombs. And this, together with the abnormal fibroblast activity, makes this IPF. Now, a lot of work has been done on scarring and abnormal fibroblast activity, and in fact, most of the drugs that we have today targets this, but relatively little is known of the abnormal alveolar regeneration. So the question we have in the next 10 minutes is really how has the IPF lung really lost its ability to regenerate normally? And what is the impact of this defect? And what is the role of the immune cells that we see are packing up the interstitium in IPF? And here, we want to go back to the basics and to answer these questions. And we look at the tissue of the lungs of IPF patients and use and develop tools that were never available to us before. In the next 15 minutes, I'd like to talk about this paper, particularly this paper here, which both have been driven by one of our co-chairs here, Dr. Weeratunga, who was a phenomenal research fellow at the Institute and has really pretty much trumped a lot of our Oxford graduates by publishing not one but two Nature Family first author papers during his time. So I'll be talking about something called the tissue single-cell imaging mass cytometry, and I want to first give an analogy of what this is about. So imagine if our routine H&E pathology slide could be more than just broad cell types and broad tissue structure. So it's a bit like going into a marketplace, for example, where you can, instead of seeing throngs of crowds, you can actually make out who the individual people in the crowd are, whether they are buyers for the family, an old chap, old gentleman moving around looking at the market, or the seller, and what the sellers or the market traders are actually selling, which type of fruit they are selling. And then imagine that we can see who are actually sitting together and talking to each other and what they're talking about. And this is what tissue imaging mass cytometry at a single cell level will do for us, and I hope to take you through this in the next few slides. So this is the tool, and the tool is really just, I don't say just, but it's a method where we use not 4 or 5 protein markers, but up to 35 to 40 protein markers, which are tagged not with fluorescence, but metal-tagged antibodies, which allows us to look at each single cell with much greater clarity and accuracy. And one of the most important things about this tool is that it allows us to circumvent the problem of autofluorescence, which has plagued the lung immunofluorescence for decades, in addition to providing a high-resolution picture for us. So this is the machine we use. We take the paraffin-embedded lung section, put through this, and the machine ablates each section systematically of these lung sections that's been stained, and this is our pipeline. The 35 protein antibody panel is designed to capture the identity of all the immune cells in the lungs that we need, and also provide clarity of the epithelial alveolar cells. So for each of these cells, we not only can tell that this is, let's say, a CD4 lymphocyte, but also whether this is an activated, exhausted, or lymphocytes that produce cytokine, and so on and so forth. The pipeline goes something like this. So the lung section is put through the machine that I've just shown you after it's been cut in sequential slides. And the computer then extracts metadata, and which comprise the antibody staining and also, crucially, the coordinates or the spatial location of these cells within the tissue. This is then clustered according to a dimension reduction pipeline, and then each cell is given an identity. So unlike what we should see in H&E section or in immunofluorescence section, where a cell has a marker, each cell eventually within the tissue has a location and also an identity which is more accurate and more detailed than before. We then develop an unbiased mathematical method with our mathematicians to tell how these cells are spatially associated with each other above randomness. So for this, we borrow mathematical methods that's been used in ecology and in astronomy to map animal migrations and stars in the galaxy to determine if there's an organized pattern for this location of the cells and how they behave spatially with each other beyond random positions. We then use these methods that we've developed on biopsies that we've taken from IPF explanted lungs, which allows us to look at stages of disease from the early, intermediate, and advanced disease, and select regions of alveolar regeneration, which is what we are interested in. So the first thing we found was that there are indeed a huge number of immune cells, but these immune cells can now be divided into 16 subtypes, and the dominant immune cells are macrophages, petroleum monocytes, CD4 and CD8 T cells, and B cells, but predominantly macrophages and monocytes. There is a spectrum of abnormal-looking alveolar epithelial cells, which has been seen and described well in murine studies in mouse lungs, but for the first time being seen very clearly in IPF lungs. When we funnel them, all this information into our mathematical algorithm, we found that although there are a lot of immune cells, only 3 types of immune cells are co-located with this abnormal alveolar epithelium. For short, we call this ABI. And these are the CD206 high macrophages, CD206 mid macrophage, and the resident CD4 T cells. And the CD206 macrophage is the only immune cells that's co-located spatially with abnormal alveolar epithelium throughout the stages of disease from early, mid, to late disease. And in the final part of this work, we then ask how this CD206 high macrophage talks with the abnormal regenerating alveolar epithelial cells. And for this, we then look not just at the protein markers, but now at the 20,000 genes that are expressed by each and every of the single cell in a method called single cell transcriptomic work, and ask computationally and with the help of machine learning and AI, how these cells, what kind of evidence there is in terms of its gene expression profiling of crosstalk between ABI and the CD206 high macrophages.
Professor Ho, I'm sorry, we're running a little short of time. Can conclude the session.
Okay, thanks. Only 2 slides left. And the key thing we found was that, in fact, the CD206 high macrophages appear to be producing fibronectin, which increases the TGF-beta expression on these abnormal alveolar regeneration, and which then increases the chemokine production and brings in more fibroblasts and macrophages. And on the contrary, the alveolar epithelial cells that are abnormal appears to be producing a cytokine called MIF, or macrophage inhibitory factor, that inhibits macrophages from dying. And also increases the pro-inflammatory cytokine expression in these macrophages. So in doing so, setting out a cycle of a perpetuation of the presence of these macrophages, which then also keeps perpetuating the production of TGF-beta and in this abnormal regenerating alveolar epithelium, which then calls in more fibroblasts. So you can see here that it's setting up a cycle of inflammation and fibrosis, which very likely then contributes to this chronicity in fibrosis. So the key findings from this single-cell tissue mass cytometry study is that only 3 immune cells are really spatially associated with abnormal regenerating alveoli. No immune cells, interestingly, is found mathematically and statistically to associate with normal alveolar epithelium. So these immune cells are really a feature of abnormal alveolar regenerating cells in terms of their association. A subtype of alveolar macrophage, the CD206 high macrophage, consistently is present with the abnormal alveolar epithelium across all disease stages, and they interact with each other to set up a persistent presence of inflammatory macrophages, and it appears to impact on abnormal regenerating alveolar epithelial cells to attract and activate fibroblasts. So this is my last slide. So in conclusion, for today's physician, I'd like to propose that the diagnosis of IPF itself is important for appropriate treatment and management. For the future, advanced high-resolution tools are here, and from our own work, it's highlight the importance of an abnormally alveolar, regenerating alveolar epithelium with macrophage as a mechanism for perpetuating fibrosis. And it leads to the possibility that we can interrupt this pathway, particularly as the immune cells can be targeted with nebulizers because they are found in the alveolar space. And so to conclude, these are the people that I have to thank for all the work that have been done, particularly for the second part of the work. Of course, my clinical colleagues as well, and the team is here, and here's our chairperson here, Dr. Weeratunga, doing all the things we like to do most, which is eating. So thank you very much for your attention.
Thank you, Professor Ho. Could I please invite my co-chair, Dr. Amitha Fernando, to award Professor Ho with a certificate of appreciation.
Sorry for the lateness.